Good evening, everybody. It's Dr. Tamara here, and we're on the couch for our Q&A tonight. So while I am waiting for a whole bunch of people to hop on and have a listen, I want to give a massive shout out today to all of the people who work in the area of reproductive medicine and fertility. And if you guys know of somebody who works in the world of reproductive medicine and infertility treatment and IVF centers and that entire world, I want you guys to give a shout out right here tonight to anybody that you know and you just want to express some gratitude for. Over here in Western Australia, we have, I guess, this week come out of lockdown, or at least we've stopped wearing masks, which is fantastic. But over the last 2 weeks, it has been really, really challenging for all of our patients, but not only our patients, for all of our staff, as well as we've had to chop and change and move and shift and do new things and do things differently and try to keep our beautiful patients on track. I know the anxiety levels for people have been super high, and I'm not just talking about patients, I'm talking about staff and support people as well. So I just want to give a massive shout out to all of the beautiful nurses I work with, the amazing embryologists, the incredible support and administration staff, all of our counsellors, all of our managers, just everybody who works in the arena that I work in. I want to say thank you, because without you guys supporting our patients and getting them through, I don't know what we would have done. So thank you. And so if you guys know of somebody who has supported you, or perhaps you've supported, or you've seen some amazing things done in this arena to really help support patients, then here's your opportunity to have some gratitude and just say it out loud and be proud about that. So that's how I wanted to start tonight, on a really high note. Thank you so much for jumping on. There's some faces that I know right there. I can see some names that I know. So thank you guys for giving the time tonight. There have been some incredible questions. I love these questions. I want to just remind everybody that the answers to tonight's questions are very generic. I'm going to try and keep this as across the board and general as I can. If you have a specific question about a particular topic around your scenario, or maybe a friend's scenario, and you're looking for more specific answers, I would encourage you to go and seek help from your fertility specialist, from your gynecologist, from your reproductive medicine specialist, from your andrologist, from your GP. Go and seek some more answers to your questions. And of course, if you're living in Perth, I would very much love to have the opportunity to help you in any way that I can. So let's get going. Some great questions. Thank you for asking them. I want to start with this first one. Is it common for submucosal fibroids to affect fertility? And if so, is there a treatment for them to increase the chances of falling pregnant? Great question. I just want to try and address fibroids in the realm of fertility generally here. So there is actually a special staging categorization system for fibroids, categorizing where they are. Let's just take it back a step. So a fibroid is actually in most cases, benign growth of a tumor-like growth of smooth muscle cells made up of the tissue that makes up the wall of the uterus. That's what a fibroid is. In a very small, less than 1% of cases, they are malignant, but the vast majority of these are completely benign. And we, again, don't really completely understand the pathophysiology of them. We know that they have some genetic potential. Obviously, they can run in families or particular ethnic groups. So those with an African origin have a much higher percentage chance of having fibroids. They can grow under the influence of hormones. So in our reproductive years, when we're producing estrogen and progesterone, they can grow and they tend to grow quite slowly. Generally speaking, we're not too worried about the growth of fibroids when they're slow and when there's several of them. If there's one really fast growing fibroid, a solitary fibroid, and it's growing really fast, good idea to get that checked out by a gynecologist. But generally speaking, they're benign and quite slow growing. Can they affect fertility? Yes, they can, but it's very dependent upon where in the uterus the fibroid is actually growing and, of course, the size. The ones that we are most concerned about are the ones that impact on the lining, the endometrium and the cavity of the uterus, because that's where the embryo goes, and that's what's going to be interrupted, that endometrial receptivity, if there's a fibroid in the way. So there are 8 categories of fibroids. The ones I care about as a fertility specialist are the ones that are category 0, and they're the ones that are completely within the cavity. So if you've got the cavity itself and there's a fibroid sitting within the cavity, it's going to cause a problem with an embryo trying to implant. It will cause inflammation, it will cause irritation, and all of those cytokines and chemicals and potentially bleeding is going to disrupt an environment that the embryo wants to implant in. So an in the cavity fibroid is a problem. A category 1 fibroid where most of it is within the cavity but some of it is within the wall is also a problem. So category 1. And a category 2 fibroid where most of it is in the wall but some of it is still projecting into the cavity is also a problem. A category 3 and beyond, so 3, it's kind of a butting, touching the endometrium but not impacting on the cavity or distorting the cavity at all, tends not to impact on fertility. And then the ones within the wall and even on the outer surface, what we call subserosal or even pedunculated, where they kind of hang off a stalk off the outer aspect of the uterus. These ones are not thought to impact on fertility, so we leave them well alone. Now, yes, they can grow in pregnancy, and that can sometimes be a bit of a problem. They can sometimes, under the influence of such high hormones, they can sometimes outgrow their blood supply, causing pain in pregnancy. But I don't want to talk to that today. I want to talk to what do we do about the ones in the cavity, impacting on the cavity, and how do we manage those? So the category 0, 1, and 2 are the ones we're going to talk about. Now, the evidence suggests that if we remove the part or the whole of the fibroid that is impacting on the cavity, we can significantly improve pregnancy rates and decrease miscarriage rates. So a hysteroscopic myomectomy, meaning going inside the uterus into the cavity with a camera through the cervix and using a device, either a receptoscope or, in my preference, is a MyoSure device, and literally chomping away at that fibroid tissue and removing it and normalizing the cavity is the best way to manage it. And it depends on the size of the fibroid, whether you can get it all at once, whether you can get most of it. Some people, we have to go back and do more than one procedure. But that is by far and away the most effective way of reducing the impact from a reproductive health infertility perspective. We leave the ones in the wall. We leave the ones on the outer aspect of the uterus. They're not thought to impact on fertility. What about the ones that extend all the way through the wall and can also impact on the cavity? Well, you want an advanced laparoscopic surgeon to be removing those laparoscopically, so keyhole surgery through the tummy. There is quite a bit of complication or morbidity associated with that, lots of bleeding. You're also going to have a full thickness scar on the uterus, which will have impact issues in pregnancy itself. And there is the potential to cause scarring in the endometrial cavity and development of Ashman syndrome. So it's not for the faint-hearted. I would definitely make sure that you go and see if you've got a fibroid that's of a problem. Go and see someone who is a skilled endoscopic surgeon in this particular area, and it can be managed. From a non-surgical point of view, there's lots of different medical treatments that have been tried. The newest drugs on the market, these things called sperm, selective progesterone receptor modulators, have not really been found to be safe. And so they were on the market, they're being taken off the market, so we don't really use those anymore. Most of the other sort of interventional radiology procedures where we use cryotherapy or we use ultrasound guided coagulation, so burning it, unfortunately, we think might negatively impact on fertility, so we don't recommend it, and that also goes for uterine artery embolization. So hopefully that's really helpful. Hopefully that answered the question. Does it help? What can we do to help fall pregnant? All right, question number 2. I've got these in some sort of order. Number 2. Oh, I really like this one, and I'm going to try hard not to spend too much time labouring this. And if any of my residents are on, this is probably a really good learning for you guys too. Can you explain the different IVF drugs, what they do, and why you would choose to use that drug? Gosh, this is like an hour-long lecture. So I'm just going to try and give you a little bit of a summary of the different types of drugs. But honestly, the best people to take you through this are actually the amazing fertility nurses. So if you are with a fertility centre, I would spend some time with your fertility doctor or with fertility nurses going through the drugs. But when we do IVF, we do something called controlled ovarian hyperstimulation. So every single month, normally, you would recruit a group of follicles and one follicle takes off and that's what you ovulate, and the rest of these just die. That happens every month. And the amount of follicles that are in that group that you are releasing is actually completely dependent on what your ovarian reserve is. So some people release a lot, they've got a really high ovarian reserve. Some people don't have a very high reserve, and so they release very few. It's amazing how the ovary actually knows how to calibrate that. So you release this group of follicles. Now in IVF, our intention is to actually recruit that entire group of follicles, all the ones that you have released, so that we leave none behind. We don't lose any of those because we have a much higher chance of developing an embryo and ultimately a pregnancy if we've got a group of follicles and eggs to choose from than if we've only got one to rely on. And so we need to use medication in order to hyperstimulate, grow all of those follicles up to that dominant size to then enable egg collection. So the hormone that does that normally, that grows that dominant follicle and therefore egg, is FSH, follicle stimulating hormone. So what we do in IVF is we actually use recombinant follicle stimulating hormone, or recombinant FSH, in order to recruit that group, but in a much higher dose than what your body would do to just recruit one follicle. So the main medication that we use is recombinant FSH most of the time. And you may recognize that as medications like Gonalev, Puragon, Recavel. These are all the Australian names, obviously. I'm not getting paid by anyone to say those names. They're kind of the most common ones that are actually Elonva. They're all the common drugs that are used in that sphere. And to be perfectly honest, it's personal choice with those. Another medication that you may have heard of is recombinant LH, luteinizing hormone. Now, luteinizing hormone is the one that you would normally surge to make you ovulate off that follicle. And in some women, having additional recombinant LH will actually improve the recruitment of follicles. That may be too much scientific information. So some women will also have recombinant LH in their cycle. Luvaris is the one that comes to mind for me. There is also a group of medications based on the chemicals that, how do I say this, have been made from the urine of menopausal nuns. HMG, HMG, just remember HMG. And this particular drug has both FSH and LH qualities to it. So it's kind of a hybrid of all of them. And so the most common one that you may know about is something called Menopur. Pergoveris also is a combination drug, has both the FSH and LH component in it, but that actually is a recombinant version. So you can kind of, that group is together. Now, the other drugs that are often involved in an IVF cycle, remember I talked about growing up these follicles together? Well, we actually want them to stay together, not be all spread out. because sometimes if you grow really big ones, you can leave some other ones behind. So we actually want them to grow up as a group. And so another group of drugs that we use are GnRH analogues. GnRH is gonadotrophin releasing hormone analog. And what it does is it helps the brain to either stop producing or flare producing your own FSH and LH. So you might have heard of the antagonists such as orgalitran is one of them, cetrotide is another, or you might have heard of agonists, which include things like Cineral or Decapeptyl. So that's that group of drugs. And then the other group of drugs that you may have heard about is your trigger drug. And the trigger, well, as you know, in a normal cycle, you flare LH to make you ovulate. Well, there's a group of drugs based around HCG. HCG is that pregnancy hormone that we often measure when we're pregnant, but it's actually HCG that acts like LH to flare and mature the eggs in the follicles in your ovaries. So that group of drugs includes things like Ovidril, Pregnil. You might have heard of those drugs before. And in fact, Decapeptyl can also be used as a trigger. I'm not going to teach you the science behind that, but you just know that that can be used as a trigger as well. And then you've got a bunch of drugs that are used to support the lining after you've had your egg collection. So that will be things like progesterone, and you can have that as a vaginal preparation. You can have that as an oral tablet. You can have that as an injection. And Pregnil is also used to support the follicles to produce your own progesterone to support the lining as well. So without giving you too much of a pharmacology lesson, I'm hoping that that is helpful for you to understand a little bit about the different drug types. As far as what to use on whom, it really is your own individual situation. It depends on so many different factors: age, the condition that you've got, why you have infertility in the first place, and everybody's a mixed bag. So individualized treatment is really important, and that's very dependent on the fertility specialist that you are working with. I'm sorry, I can't be more specific than that, but that is really the truth there. But awesome question. Thank you so much for asking it, whoever asked that one. Question number 3. Is it advisable to take a break, oh, I lost my notes, between frozen embryo transfers, or can they be done back to back? Awesome question. Awesome question. So the purpose of a frozen embryo transfer is really just to, well, it's just to build up a nice receptive lining to be able to put an embryo back in. And there's lots of different frozen cycles that we use. Some people use hormone replacement, so we'll give a woman estrogen, and then when the lining's thick enough, we'll give them progesterone, and then we'll transfer the embryo back. So there's no follicular development in there at all. That kind of cycle, absolutely, you can do that physiologically. You can do that in a back-to-back fashion, because it wouldn't be too different than if you just went away and tried to fall pregnant each month, right? Like, there's nothing too different from that. A low-dose stimulation cycle is where we are trying to stimulate you to release a follicle that then produces the estrogen and progesterone to support the lining. Again, not really too different from what your body is actually doing it. And if you're going to do that every month, then it seems reasonable to be able to do a transfer back-to-back, transfer cycles back-to-back. How about if we just do a natural cycle? So we just rely on you ovulating to produce the estrogen and progesterone, put an embryo back. Do you think we can do that back-to-back? Well, of course, because it's just your natural cycle. The only situation where I would think, and like I'm trying to rack my brains to think, but the only cycle where I think you couldn't do a back-to-back cycle is if, without any particular means to, you produce lots of follicles. Now, it's okay to produce lots of follicles if you're just putting one embryo back. You're just not supposed to time intercourse because you don't want twins or triplets, right? So in that situation, and you've got lots of follicles producing the estrogen and progesterone, it may be difficult to then stimulate those ovaries in a subsequent cycle. So with multiple, let's say 3 or more follicles being produced, I would probably suggest have a month off and let those ovaries settle down before you try again. But the other thing to really think about is how you're feeling in your heart and your head doing cycle after cycle after cycle after cycle. It's burdensome. I don't know if anybody out there feels burdened by doing lots and lots of treatment, lots of blood tests, lots of ultrasounds, lots of waiting for results, lots of uncertainty. That can get pretty trying after a while. And all of a sudden, if you're doing that month on, month off, the rest of life just gets excluded, doesn't it? You know, like other children just get put to the wayside. You don't go and buy new outfits. You don't book holidays. You don't buy houses because there's so much riding on these pregnancies. So I know that. And so sometimes the taking of the time off is not just about the physiological aspect of this, but it is as much about the psychosocial stuff and the reconnecting to who you are and what your partnership is and what life really means is just as important. So just keep that in mind when I'm answering that question, that sometimes taking a month off actually does make an incredible difference to your experience. Number 3 of us answered that one. Number 4, we're going to move off fertility just for a bit. Let's talk about menstrual headaches, menstrual migraines. Are they a real thing? If so, what causes it? What can I do to prevent it? I tend to get cluster headaches around my period. It lasts for up to 3 days every single month. I hear you, sister. Hormones are a funny thing. And we do know that changes in estrogen particularly can induce change. So PMS happens in that sort of week leading into your period as the hormones are starting to drop back to baseline before you start another cycle. Menstrual migraines, so migraines are the most common headaches that are associated with hormonal change. And they can be migraines with aura, so the neurological symptoms where you might get sort of numbness or spots in your vision. That's a migraine with aura. That can happen just due to your normal cycle. It can happen with the pill. It's actually a contraindication for the pill. But even migraines without aura can increase leading into the period. So it's not an uncommon scenario. And whoever asked this question, you put it beautifully, that you get these headaches that are kind of 3 days out from when your period happens, and then the period comes and it kind of goes. Very typical of estrogen-induced headaches. Hard to get rid of if you're regularly having periods. Interestingly, will also happen around the perimenopause as well. We often see women complaining of an increased frequency of migraines around the perimenopause. And the main reason for this is that they're getting sort of suboptimal amounts of estrogen as they are nearing the menopause. So it's a problem. The logical way then of treating these menstrual migraines is to just stop the variation in the estrogen. And so for women, young women often will use, if we can, if there's no aura, we'll use the combined oral contraceptive pill so that the amount of hormone they're seeing is like that as opposed to like that. Or if it is around the time of menopause and the headaches are bad, we'll actually think about including hormone replacement therapy again to ensure that the amount and the, lack of variation in hormones is much more stable for a woman. And often that's enough just to kick the actual headaches themselves. So I hope that that's really helpful, but that's not uncommon. Do you know some people can actually get seizures around the time of their periods as well, catamental seizures that can happen cyclically. PMS, as you know, PMDD, all of these happens due to this change, particularly in estrogen, but this change in hormones. So for me, headaches, chocolate. For some other people, it's their change in estrogen. Okay, question number 5. I hope this is helpful. Tell me, guys, if this has been helpful for you. Make sure you drop some comments. Don't forget to keep posting questions. We like to see those questions by about Sunday night. Remembering too, as we're going, that all of this is very generic information. If you have more specific questions relating to your situation, don't forget to go and see your fertility specialist, your gynecologist, your reproductive endocrinologist. But hopefully this is helpful just to get you started. Oh, good. Thanks for the thumbs up. Okay, question number, where are we? 5. Okay, I'm going to kind of wrap this up, combining question 5 and question 6 together. And this is about lifestyle and fertility. So question 5 is, does a high sugar level intake, so eating a lot of sweet chocolate, I love chocolate, especially like 70% cacao, right? That's what we oh, I'm so glad, Natalie, you thought that was a valuable answer. I'm so pleased, my friend. Make sure that you tag any girlfriend that you know that needs to know this information. Does eating a lot of sweet chocolate daily, my God, that'd be fantastic, have negative impacts on sperm quality? I'm guessing you're asking that on behalf of your partner. Okay, I'm allowed to be the nag, but you're not, right? Okay, so here's my take on this one. Too much of any one thing is not necessarily good. That applies to alcohol, that applies to smoking, that applies to sugar intake, that applies to processed foods, that applies to eating chips on the couch. Like, too much consistently is not good for our general health and well-being, but it additionally sperm health. See, sperm is a really great barometer for a bloke's health. It really is. And if your bloke is eating too much sugar and probably sitting around putting their feet up, maybe watching a bit of TV and maybe having the occasional beer, am I being too stereotypical here? All of that will ultimately culminate in poor health. It might be obesity. It might be raised cholesterol. It might be insulin-dependent diabetes. All of those disease processes are about inflammation, and inflammation is about free radical activity. Sperm don't like free radicals. Oxidative stress is an issue for sperm, and we know that oxidative stress can be measured in sperm samples. We measure oxidative stress in sperm in the form of DNA damage. And we know that DNA damage to sperm can impact on the ability to fertilize an egg and ultimately create an embryo. So in answer to your question, can it have a negative effect? Absolutely. If there's too much of a good thing all of the time. So yeah, maybe chocolate 1 or 2 times a week, but not every day. But I'd say that for any health condition. Does having a healthy diet, such as a Mediterranean diet, help male and female fertility? Yes, the Nurses' Health study showed us this, that a diet that's rich in good quality oils, fruits and vegetables, interestingly, a full fat, so lean meats, but full fat dairy, nuts and legumes, you're much more likely to be fertile than if you are having your typical Western diet. And I think that applies to most major health conditions worldwide. The Mediterranean diet has the most evidence out of all the different dietary types to improve general health and well-being, but also for fertility health. So yeah, get stuck into the Mediterranean diet. Does taking supplements help as well? Ugh, that's such a generic question. Really hard for me to give you a really good answer on that. Every woman should be on folic acid. No, hands down. Every woman should be on folic acid at very minimum. If you're not getting your green smoothies in every day, if you're not eating an optimal amounts of fruits and vegetables, I do think an antioxidant supplement is helpful. I think if a man has oxidative stress proven in his sperm, I think that an antioxidant preparation is helpful. Is the evidence conclusive on this? No. Is it harmful? No. Therefore, take it. Make your man a green smoothie every day and get his supplements into him. I think it is ultimately going to do more benefit than harm. All right, last question. Hopefully that was helpful. And that kind of answers question 6, which is what would I suggest to support a successful IVF treatment? Really what that question is, what can you do to improve your outcomes as best as possible? Be kind to yourself. Be kind to yourself. Don't beat yourself up. But eat well, drink less alcohol, don't smoke, de-stress. Mindfulness is really important. And however you practice mindfulness, it might be meditation, it might be acupuncture, it might be yoga classes, anything that helps you to be present and reduce those stress hormones is going to be helpful for you to get through the burden of IVF treatment. You know, IVF treatment, look, any fertility treatment is difficult. It's challenging in every possible way, emotionally, socially, financially, relationships, work. Like, it's challenging. That's not lost on us, let me tell you. So look after yourself, you know, care for yourself, love on yourself, give yourself some time, and look after your physical being as well. Don't over-exercise, don't under-exercise. But seriously, give yourself a break and just give yourself a big hug, because, you know, what you're doing is an incredible thing, and, you know, celebrate the power within you to be able to step into that space. I think that's it. There was one more question. Do you want me to go through one more question? There's a few more people just jumped online. Maybe I'll go through this last question because this is actually a really interesting one. Somebody asked me the question about celiac disease and fertility, and particularly miscarriage. Great question. So here's the thing. Celiac disease is an immune-mediated destruction of the... Oh, look at those love hearts. Thanks, guys. I really appreciate that. Sometimes there's a bit of a struggle when you're talking to yourself. I hope you're saying the right things. So it's an immune-mediated destruction of the lining of the gut. And it is thought to be genetic, but has environmental influence by consuming gluten-containing foods, right? So the management of it, I'm not going to go through the diagnosis of it. I'm not a gastroenterologist, but the management of celiac disease is a strict gluten-free diet. Does it mean that everybody who's gluten intolerant out there has celiac? No. I'm talking about medically proven celiac disease. We know that, I'm just going to talk women for a second, but we know that women who have proven celiac disease do have a higher incidence of infertility, miscarriage, pregnancy-related problems such as preterm birth and growth restriction. They're also more likely to start their periods late, and they're also more likely to have menopause earlier. So that's really interesting. Why? Why is this so? Well, we think that it probably has to do with inflammation in the body, the autoimmune condition itself. And we think it may also be associated with the nutritional deficiencies that people who have uncontrolled celiac disease have. It's theory, it's not been proven. This is all kind of relationship stuff, but no causal, this causes this. It's kind of correlational stuff based on registry data. But here's the really interesting thing. If you have celiac disease and it is well controlled, so you're on a gluten-free diet and your gastroenterologist or surgeon has proven that on a gluten-free diet, the damage and destruction to your lining of your gut is back to normal, so that it's proven that the gluten-free diet actually works for you, then you are brought back to the rates of infertility, miscarriage, stillbirth, pregnancy complications, growth restriction, the same as a woman who doesn't have celiac disease. Amazing. Amazing to think that just by diligently eliminating gluten and therefore reducing the inflammation and maybe even improving the nutritional absorption, that you can kind of normalize your risks even if you do have celiac disease. So there's very few conditions where we can say that conclusively, but the evidence seems to suggest that even if you have celiac disease, as long as it is well controlled, your risks of miscarriage, infertility is no different than if you didn't have celiac disease at all. But it's all in the management of your disease. So when you go and reach for that sourdough bread, think twice. Think twice about what you can potentially do to actually improve your chances of conceiving and having a term healthy baby and enjoying the experience. So I hope that was really helpful today. There were some fantastic questions that were answered. There was a little bit of gynae in there, a little bit of fertility, a little bit of male fertility health. Thank you so much for asking. Thank you so much for joining. Once again, I just want to reiterate that this is generic information. It's not pertaining to any one particular case. If you have particular questions about you, then make sure that you head along to your local specialist. If you're in Perth, I would love to see you and help you in any way that I can. But most importantly, girls, guys, I am on a mission. I am on a mission to empower people with as much evidence-based knowledge as I can. If there is something tonight that has really resonated with you for a friend or a colleague, please don't hesitate to tag them or share my Instagram link. I know there have been other questions asked about adenomyosis and endometriosis. I have answered those on 2 previous Instagram TV last week and the week before. So if you really want to know more about endometriosis and adenomyosis, head back to IGTV from a week ago and a fortnight ago, and you'll find the answers to those questions. Have a beautiful rest of your week. Thank you so much for joining me tonight. I really appreciate the fact that you've spent the time. Be grateful. We're so blessed. We're so lucky to have what we have in the world. And don't forget to tell somebody how much you appreciate them. See you soon.